ma'am. Thank you, sir. May I call upon Dr. Reyuka to present a memento to Dr. Chakravarti and Dr. Rajendra Prasad. Thank you, ma'am. Thank you very much.
After the wonderful lecture by Professor Kaduri, we move on back to the AKI. Today's topic is post-cardiac surgery. We are always apprehensive of cardiologists and cardiac surgeons, but they seem to be the cardiac common causes of injury in our day-to-day life nowadays. But we have moved on from that. We lose dehydration, malaria, infections, AKA, and now with the complicated setup of AKA communities. And cardiologists contribute a large number of AKI at present. Cardiac surgeons also responsible. But the last few years, I believe the AKA following cardiac surgery, they switched off from one pump to all pumps come out. And today to speak on that, Dr. Ilambo is here, and Dr. Saha introduces us.
Dr. Veerappan. Yeah, Dr. Veerappan is currently he's a famous Veerappan, not the Dr. He is currently the Associate Professor, Pulmonary Nephrology, Christian Institute of Medical Sciences, Pondicherry, and he is MBBS from, I think, Pondicherry only, MD also from the same institute, and came from CNC Bangalore. So several competitions. Without wasting further time, I invite Dr. to start his talk. Dr. Veerappan.
Thank you, sir, for these kind words. First of all, I should thank the Secretary and organizing team, the scientific committee, for letting me share the same guys, a lot of eminent speakers before me have spoken. And why should we listen to AKA post-cardiac surgery in this afternoon post-cardiac session? Post-cardiac surgery, AKA, offers a unique opportunity to know when the AKA starts, what happens, what are the biomarkers which are released after an episode of acute injury. We have predictive models as to which patient of the lot are more likely to develop acute kidney injury. So this is a prime recipe for research to give answers to not just treating AKA post-cardiac surgery, but AKA in general. So that is the importance of, and that is why a lot of studies, a lot of trials have been published on this particular field. So I come from this hospital where a lot of brown buildings are placed opposite to the beach. It's 150 kilometers from Chennai. AKA after cardiac surgery, if you look at the incidence, because of the current rifle and Achille criteria, the actual incidence seems to have gone up. The actual incidence of acute kidney failure seems to have gone up. But actually, it may not be the real scenario, because the dialysis dependent acute kidney injury, the incidence stays at 1.5 to 2. So it just must be because of the newer classification we have embraced of late. But what is very disturbing is the mortality seems to have not changed over the decades. So that is really disturbing. So the people dying with AKA post cardiac surgery seems to be the same. The same 1%, 2% of them seems to be dying. dying, but only the incidence seems to have increased with time. CVPG only surgery, the risk as a function of preoperative serum creatinine increases as well as the duration of cardiopulmonary bypass time. But when you do CVP plus a valve surgery, the risk is almost double. And small changes in renal function cause significant increased incidence of acute kidney injury. So I think we have started to understand these days. With just 0.1 milligram per deciliter increase in serum creatinine post-op, the mortality tremendously increases. And this also shows here that immediately post cardiac surgery, we expect a drop in serum creatinine. And so even a normal creatinine post cardiac surgery will not be really normal. But what we generally expect is either a normal or a slight drop in serum creatinine. So unfortunately, we are staring at this reality. Despite advances in the bypass technique, intensity of facility, delivery of dialysis, the mortality and morbidity associated with post-cardiac surgery, acute kidney injury has not changed much. And Indians are at higher risk of acute kidney injury post-cardiac surgery. So we unfortunately have high risk of a lot of stuff. High risk of cardiovascular disease. And here also, we have a high risk of kidney injury post-cardiac surgery. So early recovery of the immediate post-surgery period actually tells us that recovery is more likely to happen. So this slide shows that there is a 9% against 18% against 26% decline in creatinine in the next 24 hours after the surgery. The chance of survival keeps improving. So more the improvement in the initial one day predicts long-term survival. So that is something, the gross marker to tell us what is expected in this patient. And if you look at these risk factors, most of them relate to an impaired renal perfusion, either pre-surgery or during the surgery, or they represent the decreased renal reserve. So that's the reason why female gender who are genetically programmed to have a lesser reserve, people with chronic obstructive pulmonary disease, who most often share many of the risk factors of CKD, diabetes, cardiovascular disease, renal insufficiency, congestive heart failure, reduced cardiac function, need for an emergency surgery, cardiogenic shock, and major vessel capillary disease. It's all patient-related risk factors. The procedure-related risk factors like length of the bypass time, cross-lamp time, and as Madam pointed out, after being off-pump, the incidence of CKD has decreased, but nevertheless, they have not decreased tremendously. And it's controversial whether pulse time flow during the bypass time is better than the non-pulse time, even though evidence seems to suggest that pulse time flow is slightly better. Hemolysis and hemodilution also contribute. So we'll see briefly of the selected risk factors, which I thought were interestingly modifiable. And post-op hemodynamic instability, further necrotoxic systemic inflammation, and reduced ventricular function post-op also further adds to the already present problem. So before we go further as to how all we can retard the progression or prevent production, we'll have a look at predictive models. So what does this model help us? It helps us to tell us our patients, our counsel them what is the risk. What is the risk of them developing acute kidney injury? Because if you develop acute kidney injury, the chance of a 1 year survival is only 10%, requiring acute kidney injury requiring dialysis. It's so bad. So if the risk is so high, probably we have to think twice if we really have to operate on it. And it also helps us to plan our research. We can plan our trials on people who are high risk of developing acute kidney injury as against involving all patients, including low risk patients. An allocation of clinical resources, and also it can become a benchmark as to what is the observed rate as against predicted rate of acute kidney injury in a particular institute. So Cleveland Clinical Risk Score by Dr. et al. Is a well-validated preoperative risk factor predictive score, which has been quite well validated. And as you can see here, with increasing risk, the risk of developing acute kidney injury increases tremendously. Somebody with a total score of likely to have a 2 high chance of having acute kidney injury requiring dialysis. So all these things are requiring acute kidney injury requiring dialysis. So it is only more understandable, like when you add on with the pre-surgery risk factors, you add on the intraoperative risk factors, the predictive model should be better predicted. So that's what these authors have done and claimed. So the AUC, if you see, they involve the pre-surgical as well as the intraoperative risk factors. The AUC was 0.9, which is pretty good prediction. But here, as of now, all these models does their job because they predict who are more likely to have dialysis dependent acute kidney injury. But we are not interested in only that. We want to know who are all going to develop acute kidney injury for 2 reasons. One is any acute kidney injuries is bad in the long run. And secondly, it will help us to plan better trials and better interventions subsequently. So all these predictive models are good in predicting dialysis requiring AK, but we need other scoring systems to predict even non-dialysis requiring AK. So to know and to understand why AK is special in cardiac surgery patients, we also need to know what is the bypass circuit of these. So this is something like our dialysis circuit. So we have a cardiac suction which helps to recycle the blood which is lost during the surgery, and a reservoir bag containing blood, and heat exchanger to maintain the temperature, and an ECMO, an oxygenator, roller pump, filter, and then goes back into the IR. So here, if you can see, as you can see, okay, the blood is exposed to a lot of extracorporeal substances. So that's where really the problem starts. So here, if you see the intraoperative risk factors or the physiological factors, it's called acute kidney injury. One is reduced renal perfusion. So the perfusion pressures during bypass, it's not what we generally maintain. It's around 50 to 70 millimeter mercury. So there is a hypotension, and it's a non-pulse type flow. There is a lot of vasoactive agents which are given, anesthetic agents which are given, and embolic events. Embolic events, I think, particulate, gaseous material, and we don't know how much the arterial embolism contributes. And there is bypass-induced inflammation, nephrotoxins which are released in the circuit. We really don't know how much of hemoglobin is released. We know they are released, but we don't know how much. There is free radicals, oxidative stress, and there is an intentional hemodilution, which sometimes people are more fond of doing it. With a fond of doing it. So I will talk about that later. So about bypass circuit, so it delivers around 2 liters per minute per meter square at the pressure of 50 to 70. And people found out that there's no change in the renal function when you try to increase the pressure beyond 70. So that is the reason why people kept at 70. And with pre-existing acute tubular necrosis, we should understand the autoregulating capacity of the kidney is different. So when you have even 90 millimeter mercury in a patient with a pre-existing acute kidney failure, if you need etiology, the autoregulating capacity of the kidney is no longer the same. So there are more vascular insults. The same thing happens here. So that is one of the reasons why when you do a CABG, any cardiac surgery, the immediately after angiography, chances of developing acute kidney injury is higher. So it's possible that they have a pre-existing acute kidney failure caused by the contrast, further worsens with the procedure. So mainly the bypass contributes to the problem by inflammatory state, and secondly hemodilution. So this inflammatory state, when I first happened to see these patients, were looking like a rapid sepsis. So that's what I call it. It looks like as somebody got into rapid sepsis in 1 hour's time. So the contact with blood components with the artificial extracorporeal circuit, it elicits an intense inflammation. It's something like ischemia perfusion injury. And there's also possibility of endotoxemia, operative trauma, non-pulsatile blood flow, pre-existing ventricular dysfunction, all adding on to the inflammation. So if you see, they present with multiple organ dysfunction or myocardial dysfunction, coagulopathy, vasodilatation, capillary permeability, hemolysis, pyrexia, and also subsequently increased susceptibility to infections. So there is activation of neutrophils, vascular endothelium, platelet activation, release of one area that we can easily prevent in elective cases, postpone the surgeries to a point where transfusion requirement can be predictably lower. On and off pump cardiac bypass surgery. So what this slide shows is that in the meta-analysis they found that they definitely off pump mortality is lesser, but somehow they couldn't show the similar reduction in acute kidney injury when it comes to off pump, even though there was some trend towards it. The small single center studies have shown their AK incidents are lesser, but when you're just doing a cardiac bypass and your surgery is not a complex surgery requiring valve replacement, then there is nothing much to choose from. The two, both are almost the same. This interesting study I came across. This talks about duration of blood storage. So the older blood, the orange one is the blood that was transfused within the first 2 weeks. The one other blue one is beyond 2 week time. So they found that increasing storage, in addition to increasing volume of blood being transfused, there was an increased risk of acute kidney injury. So there's something in the blood which, in addition to all the circuits and other risk factors we have just talked about, also predispose these people. Naturally, it is only natural to think about a drug which we use more often, erythropoietin, to reduce both the transfusion requirement pre-op, as well as in helping to harvest autologous blood pre-op, and also for third reason, that is to reduce inflammation or cause changes in the inflammation milieu. So we found studies. There is a meta-analysis which is awaited from the Cochrane group, whether how good is it in even minimizing blood transfusion, because there are groups which have shown that giving erythropoietin actually does not help much in reducing the actual blood exposure, either combining autologous and allogenic. But there are studies which have shown, studies more often have shown that there is a reduction in the blood requirement post-op or intra-op. And the procedure also is cost effective. When erythropoietin is used for renal protection in animal models, they have done fantastically. But in human studies, it's not been recreated yet. And biomarkers, which I will briefly touch upon in the subsequent slides, it helps us to know what exactly is happening at a molecular level, so that helps us to reconfirm what we are doing is right or wrong. Here, absolutely there is no significant change in the inflammatory markers in people who have got 20,000 units versus 40,000 units versus nothing. Hemodilution in acute kidney injury, people thought about it because with hypothermia, with reduced blood flow in the bypass artery, people believe that because of viscosity induced by hypothermia as well as augmented by the hypoperfusion, which will also contribute to changes in the renal blood flow, which will further cause acute kidney injury. And secondly, it helps them to save blood being transfused. So that's why the hemodilution was used commonly in patients undergoing cardiac surgery. But what they found was that when the hemoglobin fell below 25%, it was associated more often with acute kidney injury. So whenever your unit is trying to do it, this is what we should tell them. So burden of atherosclerosis post cardiac surgery. So there is absolutely no active research in this area. But this particular study published some time back from a series from John Hopkins University, which looked at atherosclerosis in autopsy of patients undergoing various surgery and also subgroup analysis. They looked at cardiac surgery. So what they found was around And atrial embolism is many times hidden well because of the subacute presentation. Some of us have
5 more minutes, please.
the subacute presentation of atrial embolic kidney function makes it difficult and makes it hidden. There are percutaneous devices which are being tested in carotid, preventing carotid embolism. So it's only, so there's an area of again interest where preventing embolism to kidney could actually change the acute kidney injury instance. Antifibrinolytic therapy is definitely useful, except that you should not use the drug which has been withdrawn from the market, carotid. So other drugs have shown that they protect from blood transfusion and thereby indirectly from acute kidney injury. And when the cardiologist wants to do a CABG same day or the next day after a pulmonary angiogram, you should ask him to wait, because this is what this group said. That if you do a CABG within 24 hours, the risk of acute kidney injury is high. This has been reproducibly shown in even other trials. In brief about the biomarkers, why they are important in cardiac surgery is because the serum creatinine is no good. And urinary biomarkers, especially NGAL, have been well validated in a lot of trials. And you can see here the AUC is 0.998, which means it's extremely good. And they are increased within 2 hours after bypass surgery. So, and they are commercially available in Europe these days. So that tells you when exactly and which patient is developing acute kidney injury. So that helps us to direct our therapy to patients who are having acute kidney injury pretty early, rather than treating the whole group, which makes the trials more difficult and the power of the trial also drops. Kidney injury molecule 1 needs more validation, even though they've been used. The statin Z is another marker, but again they're not as good as NGAL. Urine has a very good AUC, but again they need further validation. Polyuria is no good. They don't tell you whether the patient will develop acute kidney injury or not, and whether the injury is reversible or not. Pharmacological interventions are largely failed. I just want to highlight only on phenoldiprate. It's a drug which has been used. The drug suffers from hypotension when used because of the vascularity benefit, and we have got many reports about their use. But what most trials like this drug also suffered is that they don't target the group which are the highest risk of acute kidney injury. They target the entire cardiac surgery as the same group. That is where the undoing happens. So here, phenoldiprate, when done in a pediatric group, was seen that the urinary NGAL was significantly lesser in the group, the white bars, which was given phenoldiprate.